Good.
That's the reason why.
Good to see you.
Text might be like WhatsApp. I don't
Surviving fellowship.
and how, I understand.
Thank you.
Doing well.
Thank you. Oh. Have I do it?
Yes.
It's on the side.
Yes.
This one. It's at the top.
Is Rosen still Medical Science Building? MSB?
I have to get your opinion later today. Make sure I'm not feeling super sensitive about this.
Okay.
They're probably.
I trust your judgment regardless. Either way.
No. I'm asking for you guys. He has to get out the space.
Yeah, you have
He has to get out the space.
at the end. Hey, what's up, man? You ready? I am. I want to. How is?
Do I use the department ID number or do I get reimbursed? How does that work?
You use the department ID number. Anna Chavez has the number.
Okay.
She can give it to you. But she sometimes. Well, wait, is it for here or for somewhere else?
That's somewhere else.
Yeah, you reimburse.
Oh, really? Okay.
Yeah.
Okay.
What you do is you would at the end she takes all those bills and she sends it at one time. But if it's for something here on campus,
Got it. So I'll just set it up.
yeah.
So I told him yesterday, like I did on conference. And I was like, oh, he's actually presenting to do something.
Okay. Good afternoon, everybody. Is this on? Okay. Where's that guy? Can you guys hear me? Hello? All right. Good afternoon, everyone. Thank you for coming to our internal medicine grand rounds. Today, I have the pleasure of introducing two speakers. Our first presenter is Dr. Harold Rivner. He is currently a cardiovascular fellow at the University of Miami Jackson Memorial Hospital and is interested in pursuing a career in electrophysiology. Dr. Rivner obtained his medical degree from the Medical College of Georgia and Augusta University, where he finished at the top quartile of his class and was inducted into Alpha Omega Alpha Honors Medical Society. He completed his internal medicine training program here at University of Miami Jackson Memorial Hospital and is considered one of our best and our brightest. Dr. Rivner published multiple first author publications in higher impact journals. He continues to make amazing strides in the field of cardiovascular disease. And please join me in giving a warm welcome to Dr. Harold Rivner as he gives an excellent presentation on big data and risk modeling in cardiovascular disease.
Can everyone hear me? Thank you everyone coming today. So this afternoon we'll be discussing big data and risk modeling in cardiovascular disease. So we're going to go through the concept of big data, explore how big data can answer clinical questions, and then I'm going to show two examples based on current research I'm doing. One will be in CHA2DS2-VASc score, see if we can apply it to heart failure patients without atrial fibrillation, and the other will be a new heart failure mortality score. So what is big data? So big data is using extremely large data sets that can be analyzed computationally to reveal patterns, trends, associations that you might not be able to see with a smaller data set or might take many years to go through. It's a hot topic in medicine right now. The Institute of Medicine is arguing that big data can allow for large retrospective analyses to detect trends associations quicker and earlier than traditional methods, and this can help solve problems quicker. So in a traditional research study, it's very tedious data extraction, especially for retrospective analysis. I'm sure other residents and students can commiserate with me going through data and pulling out ones and zeros and putting in an Excel sheet, how time-consuming and tedious that can be. And you're limited of small numbers because you're limited by your manpower. Also, you're counting on people to be able to go through the chart and collect the data accurately and precisely. It's very time-consuming. In contrast, big data leverages existing databases. You have large numbers, you can do quick iterations. If you forget to grab a variable, it's just changing your code. It's not going through the whole chart again. And you can run automatically. In some cases, the data can be analyzed in real time, and it allows itself to newer algorithms, machine learning, which we'll touch on a little bit. It's maybe a little too advanced for this discussion. So for our example of big data, I'm going to show how we can use the VA informatics and computer infrastructure system. This is a large database that's already made. It's provided by the VA. You see here, there's over 130 VISTA ACE systems. So pretty much throughout the entire United States, every VA, when they put something into CPRS or the EMR you see, it goes into a back-end database that's already in a SQL server that you can query. So this includes, you see in the orange box, includes patient information, inpatient, outpatient encounters, their medication history, their labs, micro, vital signs. You think of it, you name it, they have it somewhere in that database that you can query. So from this data, it's raw data. It's spread out different encounters. It's in with patient identifiers and numbers, and you have to pull from a bunch of different tables. If you're able to do that, you can create a main data table that includes patient information, their medications, their demographics, and all the information from their encounters that can then be analyzed. So this is an example of the code that you have to put in. I'm not going to bore you with the detail of the code, just to kind of get a sense of how it works. And you put in many different code, and after a while, you can get it into a final table, something you're more familiar with that can then be given to a statistician to analyze and look for trends and associations. So the two study ideas that we'll be exploring today, or one is using CHA2DS2-VASc score in heart failure patients without atrial fibrillation, and also in creating a simplified heart failure mortality score. So background information. So patients with heart failure are at increased risk of thromboembolism even without atrial fibrillation. This has been estimated to be about 1.3 to 3.5% per year. Despite this elevated risk above the general population, trials of anticoagulation heart failure have not produced beneficial results. Part of this might be that it included everyone with heart failure. They don't risk stratify based on your risk of thromboembolism like we do in atrial fibrillation, for example. And we lack this current risk stratification schema that will help us target who exactly would benefit from anticoagulation. So in 2015 in JAMA, there was a study done. It looked at a Danish database of 43,000 patients, and they compared the C-statistic. The C-statistic is a statistical method we can use to see how well a risk stratification system is. 0.5 is about flip of a coin. 1 would be a perfect scheme. To see if we could take what we're using in atrial fibrillation and shift it to heart failure patients without atrial fibrillation. This is based on the original score proposed by Lip et al. In 2010. That initial study had a C-statistic of 0.6, so it's not the best stratification system in the world, but it's what we currently use in atrial fibrillation, and it's the best that we have. And then how it works is it evaluates upstream risk factors. So it looks for things that can create an atrial myopathy. Current thinking is that maybe thromboembolism is not just from the atrial fibrillation, but also from the underlying atrial myopathy. So it looks for things that raises patients' risk for that. So our thinking is that these same risk factors could also apply to patients with heart failure who are at risk for atrial myopathy. So this is from that JAMA study showing ischemic stroke, thromboembolism, and death. Just for simplification, I highlighted 1 year ischemic stroke and thromboembolism. As you see, in the patients without atrial fibrillation, their C-statistic was 0.67, which is very similar to the with atrial fibrillation, 0.64. The confidence intervals crossed. And similarly, thromboembolism, 0.63 and 0.62. So if we're using the score in patients with atrial fibrillation, based on this data, it suggests that maybe we could use this in patients with heart failure without atrial fibrillation. So our hypothesis was exactly this. The CHA2DS2-VASc score can be used to risk stratify heart failure patients without atrial fibrillation for the development of stroke and non-cerebral thromboembolism. So we used the Vinci database that I previously mentioned. This is the large American database that we already created that we could query. And we evaluated the endpoints of ischemic stroke and non-cerebral thromboembolism. For this study, we used ICD-9 codes. So when in an encounter they coded stroke or a thromboembolism outpoint, that was considered an endpoint. And we used ICD-9 codes to identify patients with heart failure and determine baseline comorbidities. So for this study, we excluded patients that developed atrial fibrillation during the follow-up period. As we know, atrial fibrillation is a paroxysmal disease. So at baseline, if you didn't have atrial fibrillation coded, but then it was coded during the follow-up period, there's a chance they had atrial fibrillation at baseline. So to make a clear distinction between the non-AFib and atrial fibrillation patients, we just excluded these crossovers. We also excluded patients on anticoagulation within 180 days of diagnosis. This was similar to the Melgard study, but now when we do further analysis, this limitation of this step was that it's a highly selected group of patients with AFib who are non-anticoagulation. So we're going to redo it for our manuscript and just stratify by anticoagulation status. So we had 110,000 patients with a heart failure admission between 2002 and 2010. About 40,000 of these were excluded, whether it was anticoagulation, they had valvular AF, cancer, or they were the crossover that developed AFib during the follow-up period. So I left this with 67,000 patients with heart failure. 51,000 of those had no atrial fibrillation. 15,000 had heart failure and atrial fibrillation. So the baseline characteristics, as you can see again, is 50,000 without atrial fibrillation, 15,000 with atrial fibrillation. As you're going to see throughout this, the p-values are usually always significant just because we have such a large number. As in the VA, so as expected, is predominantly male. While it was a majority white population, we were able to include a good racial mix with about 22% African American, 10% with AFib, and the mean age was 68 in the without atrial fibrillation and 75 in the atrial fibrillation group. Comorbidities, these are heart failure patients, so as expected, they have lots of comorbidities, diabetes, hypertension, CAD. The only one that kind of stood out as different, it was in the stroke without atrial fibrillation with about 8% versus 11.2 with atrial fibrillation. The mean CHA2DS2-VASc score was 4 versus 4.6. Their medications, about half of them were on aspirin, and a good amount were on guideline-directed medical therapy for heart failure. 60 to 70% were on beta blockers and ACEs and ARBs. So they're on treatment for heart failure. So here's the codes that we used, the IC9 codes for the endpoints. These are the codes used for stroke and non-cerebral thromboembolism. One thing of note, for non-cerebral thromboembolism, we did include pulmonary embolism. It's not necessarily thought of with atrial fibrillation, but the original LIP paper did include this in their endpoints, so for consistency, we included this as well. So then we used a Cox proportional model to study the association between CHA2DS2-VASc score and the risk of ischemic stroke and non-cerebral thromboembolism. We created a C-statistic to quantify the discriminatory property, and this was done in R. So here are our results. So this is 1 year stroke incidence. You see as by CHA2DS2-VASc score and the incidence at 1 year. Overall, you see in the bottom of the slide, was 2% without atrial fibrillation, 2.4% with atrial fibrillation. This is similar to other American cohorts. If you look through the literature, there is different incident rates given, but usually American stroke rate is lower than an European stroke rate. Then you can see the trend as increasing CHA2DS2-VASc score, you have increasing risk of stroke as expected. So this kind of validated that the data we're pulling is accurate. And then you can see the trend is present in without atrial fibrillation and with atrial fibrillation. Now, if you look at the table on the right, that shows you the p-value for differences in event rates at each CHA2DS2-VASc score, and none of them are significant, which means there's no significant difference in stroke incidence at each different CHA2DS2-VASc score. Now, in contrast, in non-cerebral thromboembolism, there's no clear trend. It's pretty flat. Part of this might be due to how hard it is to use an IC9 code for this outcome. But we didn't see, even for the atrial fibrillation, we didn't see a good trend at CHA2DS2-VASc score. Once again, our incidents were not significant at any CHA2DS2-VASc score between AFib and non-AFib. So our C-statistic. So this is for 1 year. We'll do 5 years as well in our final manuscript. Without atrial fibrillation, the C-statistic was 0.59 for ischemic stroke, 0.58 for with atrial fibrillation. The confidence intervals crossed, showing that these scores have similar utility in both without atrial fibrillation and with atrial fibrillation in patients with heart failure. For non-cerebral thromboembolism, it was 0.52, 0.54. Those are pretty close to 0.5, so it wasn't as useful for this endpoint. So our limitations. So in the current iteration of our study, there was a very high mortality rate. That serves as a competing endpoint. So people are dying, and these are sicker patients with heart failure. They're not going to have stroke. There are statistical methods to account for this that we're going to utilize for our final manuscript. Also, the AF study population was highly selected based on anticoagulation status. So we're going to address this, we're going to redo it, and we're just going to stratify based on their anticoagulation status, and we'll look at both groups to see how the CHA2DS2-VASc score applies. It was a VA population. Obviously, this is a very unique population, but it is another data set that we're validating this. This was already seen in the Danish database. Now we're applying it to an American database. And it was based on IC9 coding. It's only as good as people code. The hope is when we have 100,000 patients that have 1 or 2 codes are wrong, overall, it doesn't make a difference. So our conclusion, ischemic stroke event rates are similar in patients with heart failure, regardless of AF presence at each CHA2DS2-VASc score. And the CHA2DS2-VASc score is predictive for ischemic stroke and heart failure patients without atrial fibrillation, as with atrial fibrillation, with C-statistics of 0.58 to 0.59. And our future directions are how best to assess stroke risk in patients with heart failure and when to initiate preventive treatment. Next example will be a simplified score for predicting heart failure mortality. So the current mortality scores for heart failure require complex calculators and are cumbersome to use. They're either for inpatient only, or the large one, Seattle heart failure model, which I'll show you in a second. It requires an online calculator. It's hard to do in a busy clinic. There was a recent editorial in JACC Heart Failure in 2018, and it said that we need a more simple score that clinicians can actually use. And they suggested, look at CHA2DS2-VASc and atrial fibrillation patients. It's easy to use. It's widely accepted just because it's so easy to do. You can do it on the back of a paper. So we are hoping to take this concept and apply it to heart failure. So this is the Seattle Heart Failure Model score. As you can see, this requires a program. It's very detailed, but sometimes we have to sacrifice detail for time. And this is hard to use when you're in clinic seeing many patients. So our hypothesis will use multivariate logistic regression can be applied to our big data set to create a simple heart failure mortality tool to assist clinicians in clinic. So this is a retrospective cohort study that included 50,000 veterans of heart failure between 2002 to 2010. In this, we exclude AFib. We're going to redo it for our final manuscript with both AFib and non-AFib, so stay tuned. Data was analyzed for 5 years after heart failure diagnosis, and we used multivariate logistic regression to study the association between each potential predictor and the 5-year mortality. So from that, we created a new score, Pascal MD. This is our score at this moment. So as you see this table, it shows the variables that were significant after multivariable regression. Previous stroke, age, statin use, kidney disease, peripheral arterial disease, liver disease, male, and diabetes. We gave each of these had a coefficient estimator. For simplicity, we assigned around 0.3 to be 1 point. So if you're 0.6, it's 2 points. We're doing all this in the name of simplicity, ease of use, that it can be used in clinic and not require lots of time to compute. All these points are additive. The statin use retracts. It's protective, so you lose 2 points if you're on a statin. Liver disease, as you notice, is the highest coefficient estimator, 0.660. I think this is a surrogate marker for right-sided heart failure. Once you start getting liver disease, you're probably having biventricular failure, which is why this one is a higher coefficient. So this data, these variables make sense as things we think about. So then from this, you have a table. So this table shows the mortality at each Pascal MD score. As you see, it's a nice table because the mortality increases for every score. There's no flat, it doesn't go down, which helps make us think that it might be a valid score. And the key numbers, if this table is too much to have in clinic, you can just think about 3 numbers, 2, 5, and 9. If you're less than 2, you have less than 50% 5-year mortality. If it's 5, it's 80% 5-year mortality. And it's greater than 9, it's 90%. It's just 2, 5, 9, it's easy. It doesn't take much memorization. So for example, 1, a 63-year-old woman with heart failure, diabetes, liver disease, and on a statin. So 63, you get 1 point. Diabetes, you get 1 point. Liver disease is 2 points. Statin is negative 2 points. You add it up, 1 plus 1 plus 2 minus 2, 2 points. Remember, 2, 5, 9, less than 50 to less percent mortality, 5-year mortality. Example 2, 75-year-old man with heart failure, diabetes, prior stroke, liver disease, peripheral arterial disease, and kidney disease. This is a very sick patient, lots of comorbidities. You expect them to have a high mortality rate. So 4 points for 75, 1 point for being a man, 1 point for diabetes, 2 points for liver disease, 2 points for arterial disease. You add it up, 10 points. Don't even get that into details. Remember, it's over 9. It's over a 90% mortality. It's quick, it's easy, you can do it in clinic. This is our C-statistic and our ROC curve. Our C-statistic was 0.73 from the curve. Now comparing that to Seattle heart failure model, it compares well. Their C-statistic was 0.725, or to the CHA2DS2-VASc score of 0.68. So just using the CHA2DS2-VASc score and blindly applying it to heart failure for mortality, this was better, and it's comparable to the Seattle heart failure model, but much simpler. We use a cutoff of 7, it's a positive predictive value of 0.88. It's easy to use, and we're hoping that addition of a simple score could explain to the patients, how sick they are, so they understand that heart failure is a serious disease, especially when you have lots of comorbidities. It can help them be more compliant with their medications and just give more guidance in clinic. So further steps for this score, we want to stratify based on preserved versus reduced EF. We're going to include AF patients. We're going to include more variables just to make sure there's nothing else that could be affecting the model. I've gotten feedback that kidney disease is kind of an amorphous endpoint. So we have laboratory data, so maybe we'll include a GFR cutoff for kidney disease. And our final hope is to apply machine learning. There's algorithms such as the random forest algorithm. You go in, you don't have any preconceived conceptions of what would be indicative of mortality, and you kind of let the machine figure out, and then you see after that makes sense. So future directions. So I hope you can see the power of this large databases, especially the Vinci database. We all have access. Anyone who's a resident or fellow at the VA has access to this, which you have to step through hoop through some steps, but once you have it, it's a very powerful tool. And then once you have this as a jumping point, you can use other databases, such as the Medicare database, to validate your results. You can use different years in the same VA database, random number generators, things like that to validate. And eventually apply machine learning so we can create algorithms and risk scores quickly without any preconceived groups or notions. And we can answer clinical questions that are hard to recruit large numbers for. And we can answer these questions quickly. I want to thank my mentors, Dr. Goldberger, who's been invaluable in assisting me, giving us ideas. Dr. Marsuka, who's right here, has been very helpful every step of the way, very interested in big data as well. Dr. Juan Lopez and Dr. Fei Tang, she's our statistician at the VA, has been very helpful. But most importantly, I want to thank my wife and family. They give me the time and let me do my thing. So thank you, everyone.
Harold, that was great. You made us all very proud. Just 2 comments. One, thank you for naming your program Pascal MD after a former cardiology dean at the University of Miami. I'm sure that was in your mind. The other thing is the issue of use of artificial intelligence and bias of looking at large data sets. The very fact that you use atrial fibrillation as the distinguishing factor in the first instance, it seems to me that you almost bias that. Is there how do you correct for that?
No, for sure. But that's, I mean, I guess we're in that situation, the score is used in atrial fibrillation patients. So we're kind of overcome that bias and say maybe it's atrial myopathy, not atrial fibrillation status. And to show that, we're comparing it to what's already accepted.
Yeah.
So if we just did it in heart valve patients without atrial fibrillation, people would be like, well, it doesn't make any sense. So we can compare it to the gold standard and show, well, actually, it works similarly in both. They're kind of, okay, maybe it's really not the rhythm status. It might just be this underlying atrial myopathy.
Okay. Dr. Colbert?
So, thank you. In terms of big data, I think one of the things that people, even when we think in pop health, is the heterogeneity of populations that one deals with, which you stated that 22% of your population are Black. And so one would ask the question is, when you look at these populations separately, what does that mean for your scoring, and does it have utility in all these other populations? Because we could parse this out.
Mm-hmm.
And so big data sometimes forgets, in my opinion, that we're dealing with these heterogeneity.
I guess you can stratify by it and then see that it's similar across data sets. Would be the way you handle that.
Have you done that? Yes, fundamental question.
I'll work on it. It's a good idea. So I'll definitely include that in the final manuscript. Thank you.
Thank you, Harry. Okay, one more.
Uh-oh.
No, so Harris, that's terrific. It's a great job that we've done there. So as you mentioned, C-statistic is basically to validate your predictive model within the cohort that you're analyzing. Now, have you validated these results in another
So, yeah.
population?
So in the Chad Sebastian, we're kind of modeling after Melgard. So that was already one data set, the Danish data set. Ways we think about that, we could maybe use the Medicare data set or just applying it to different years within the VA. So make the model in between 2002, 2008, and then apply it to 2010 and 2012. Or within the same years, just do a random number generator and take one data set, make the model, then apply it to another data set from the random number generator and see if it still holds true.
Are social determinants of health included in the Vinci database?
Yeah, it's like smoking, that type of thing, or?
Well, like zip code, poverty status.
Zip code, I think there is financial data. You have to apply separately for that, but that's included as well if someone was interested in that.
Okay, thank you, Harold. That was great.
You're welcome. I hope so. You understand me? Good job. Thanks. Let me get this too.
Okay. Do you want to use them?
I turn it back on. I turned it off, so turn it back on.
This goes in there. Listen here. You have to cut it off first. You have to cut it off.
Yeah, well, it's a look. She could have watched this live. I don't know.
Hello? Hello?
Okay.
All right.
All right. Your presentation's on here, right?
Yeah.
I have a flash drive too if you want that. It's the only thing I have.
Okay. Okay, everyone. Can I get this back on? Where's that guy? This is not on. Hello. Okay. All right, guys. Sorry, the mic is not working. Hello. There you go. There you go. All right. Good afternoon, everyone. For our second presenter of the day is Dr. Sunil Iyer. He's currently one of our senior internal medicine residents here at the University of Miami Jackson Memorial Hospital, and he's interested in the career of hematology oncology. Dr. Iyer obtained his medical degree here at our very own University of Miami Miller School of Medicine. He subsequently stayed for internal medicine residency and has been one of our very best and highly recommended for chief resident here at our program. Dr. Iyer has multiple first author publications, presented at numerous national conferences, and received several awards and recognitions over the years. He continues to lead by example as he flourishes in the career of internal medicine, as well as hematology oncology. Please join me in giving a warm welcome for Dr. Iyer as he gives an excellent presentation on racial disparities in targetable mutations in non-small cell lung cancer.
Hi, everyone. Thank you, Salih, for the kind words. If you could repeat all of that later with my mom on speakerphone, that'd be great. So I'm Sunil. I'm one of the second-year residents in internal medicine, and I'll be talking about racial disparities in targetable lung cancer mutations. So the gist of what I'm talking about is we live in an era where there are certain, what we call them sensitizing mutations that have been discovered in non-small cell lung cancer, and these can be targeted with non-chemotherapeutic medications and can benefit a lot of different patients. The issue is that it seems that there are racial disparities in who really benefits the most. So I'll be talking about that. I'll start off by talking about non-small cell lung cancer. I'll talk about what targeted therapy is, and then I'll go on to talk about a meta-analysis I was part of with one of our attendings, Dr. Lopes, and one of our HEMONC fellows, Dr. Gannett Paul. All right, disclosures, none that I know of. So we'll start with a little epidemiology. So worldwide, lung cancer is the most common cancer in terms of incidence and in terms of mortality, if you combine men and women. So worldwide, there's an incidence of 1.8 million new cases per year, and there's 1.6 million deaths per year. And it's a similar story in the USA. So there's an incidence of 230,000 new cases per year and 140,000 deaths per year. So historically, there have been certain demographics that do better with the diagnosis of lung cancer and certain that have poorer outcomes. And by the time I'm done with this talk, you'll understand why. So favorable demographics, people who belong to the Asian race, specifically East Asian, tend to do better outcomes, as well as with anything in medicine, higher socioeconomic status. Unfavorable demographics, people of the Black race, unfortunately, tend to do worse and lower socioeconomic status. So before I go any further, I'll talk about the types of lung cancer. So when people think about lung cancer, they think about smoking. And, it's true that the majority of lung cancer is caused directly by smoking, but not 100% of it. So it's estimated that in the U.S., 80 to 90% of lung cancer is caused by tobacco use. And if you look at all these different subtypes, you have small cell carcinoma, and you have the different subsets of non-small cell carcinoma. You can see that smoking is the largest contributor to all of these subsets. So that's something they have in common. And you might wonder why we differentiate between non-small cell lung cancer and small cell lung cancer. Why we can't just say lung cancer, why we need a 5-letter acronym. And that's because the behavior is different. So in small cell lung cancer, it tends to be more aggressive earlier. It tends to proliferate faster. It tends to metastasize outside of the thorax faster than different subsets of non-small cell lung cancer do. And for non-small cell lung cancer, which is everything up there not in red, so most commonly adenocarcinoma and squamous cell carcinoma, the treatment has historically been exactly the same. So if the tumor is small enough, you would start by surgically resecting, and then you would give systemic therapy, which historically has been a platinum-based dual chemotherapy like carbotaxol, for example. The difference with small cell carcinoma is that in very rare cases, the surgery play a role. So typically, this cancer is already metastasized by the time it's found. And in most patients, surgery does not add any benefit. And there's also a bigger role for radiation therapy in small cell carcinoma. These patients often get prophylactic radiation to the brain. And then as smoking is declining, some of these incidences are shifting around. So in squamous cell carcinoma, where you can see there's the majority of people with squamous cell carcinoma are smokers, and there's a small sliver of non-smokers. That's changing, and it's becoming less common, whereas adenocarcinoma, where there's a much bigger chunk you see there who are non-smokers, is becoming more common relative to the other subtypes. So here are some Kaplan-Meier survival curves just to show how important early detection is for lung cancer. So up at the top, you see stage 1A1 lung cancer, which just to simplify, basically it's a solitary tumor. The A1 means it's less than 1 centimeter, and it has not moved to the lymph node, so it's really the earliest stage you can find. And the outcomes are actually really good for these patients. So the 24-month survival rate is 97%, nearly 100%. And if you take it out to 60 months, over 90% are still alive, Whereas if you look all the way at the bottom, you have stage 4A and stage 4B. And the distinction is for stage 4B, it means there are multiple metastases outside of the thorax. So it's really disseminated disease. So for these patients, the outcome has always been very dismal. So at 24 months, only 10% are still alive. And at 60 months, usually no one has survived. So before the era of targeted therapy, we've always known that there have been racial differences in how people do. So this is a major study from 1999 that was in the New England Journal of Medicine, and basically looked at Medicare beneficiaries who were 65 and above, who were diagnosed with stage 1 or stage 2 non-small cell lung cancer. They were followed for 8 years. And what was found is if you look at this curve, even at the 1 year mark, the curves start to separate, and blacks have poorer outcomes than whites. And if you look, for example, at the 6 year mark, over 30% of the white patients were still alive, whereas it was closer to 20% for the blacks. There's a very significant difference. And at the time, this was attributed to basically socioeconomic status. So blacks tend to have less screening, they tend to have less opportunity to get surgical resection. But another kind of disturbing finding that was discovered was that there was some implicit bias on the part of the physicians. For example, if you have a black patient with a certain stage of lung cancer and a certain amount of comorbidities, and you have a white patient in the exact same situation, the black patient was less likely to get possibly curative surgical resection. Some of the doctors were interviewed, and what kind of was teased out is that a lot of the physicians felt that for black patients with a certain amount of comorbidities, resection would be too risky, not worth it. Whereas for that same patient, if you were white, the physician may think, okay, surgical resection is worth it in this case. So there was some implicit bias that was found. So now we live in an era of molecular targets. So up top, you see a bunch of different acronyms. So these are all sensitizing mutations that lung cancer tumors can acquire. So the most common ones you'll see in internal medicine or really anywhere are probably EGFR and ALK. So EGFR is epidermal growth factor receptor and ALK is anaplastic lymphoma kinase. So basically, these are driver mutations, meaning they can drive a tumor to become more invasive and more powerful. And we started discovering these in the early 2000s, and since have been coming up with medications to target them. So these mutations basically lead to pathways that remain on. So they cause excessive proliferation, they may cause metastasis, they may cause resistance to therapy. And one way to think about it is that the cancer cells become addicted to these pathways. The cancer cells become so proliferative that they need these pathways to be constantly on to continue to proliferate at that current rate. So the good news is that if you're able to target these mutations, you might have found an Achilles heel in the tumor. And now we're at the point, I'll get into some studies, but we're at the point where we now have tyrosine kinase inhibitors, or TKIs, which are not chemo. They're therapies that can target patients with these mutations, and they can do better on these mutations than with chemotherapy, which is huge because chemo has always been the treatment for lung cancer. And finally, these mutations are transformative. And what I mean by that is that if you have abnormal cell growth or if you have a carcinoma in situ, if they acquire one of these mutations, it might give it what it needs to transform into an invasive tumor or metastatic tumor. And these mutations in untreated tumors are usually mutually exclusive. So what that means is that if a tumor acquires an EGFR mutation, it's not likely to also acquire one of the other ones. And the reason for that is once it acquires one mutation, it really takes off, and there's really not much selection that pushes it to acquire another mutation. So this is a study from 2010 looking at gefitinib, which was the first tyrosine kinase inhibitor that targets EGFR. And basically, in EGFR mutated patients, the patients were divided into two arms. So one arm received gefitinib by itself. So this is a TKI, no chemo. And then the other arm received the standard of care, which was carbotaxol chemotherapy. And as you can see, there was a huge difference. So the progression-free survival was twice as long in the TKI arm, 10.8 months versus 5.4 months. And the response rate was also higher, over 70% versus about 30%. And another thing you often see in cancer studies is there may be a difference in progression-free survival, but if you follow the study for years, if you follow the cohort, you might find that there's not a statistically significant difference in overall survival, but that was not the case in this study. So the overall survival in the tyrosine kinase arm was 30 months versus about 24 months. So I bolded the word metastatic because if you remember the survival curves from my second or third slide, you could see that patients with metastatic disease, their curve was basically a vertical drop. So in these patients, an extra 6 months is a huge difference. And this talk isn't about immunotherapy, but I'll speak on it for a second. So T cells, they can express a protein called PD-1, programmed death 1, and if certain ligands bind to that protein, for example PD-L1, it can kind of stop or attenuate the T cell response. And this is important in the human body because it can help prevent autoimmunity. So in mice, if you block out that interaction, you get a lot of autoimmune conditions, most commonly autoimmune dilated cardiomyopathy and glomerulonephritis. So cancer cells can also express PD-L1, which is the ligand, and this will stop the T cells from being able to attack the tumor. So this is called an immune checkpoint because it stops the immune system from doing what it wants to do. So we have checkpoint inhibitors, and the most common one you'll see in lung cancer is called pembrolizumab or Keytruda, and that basically allows the T cells to bypass this immune checkpoint and attack the tumor. So in patients with diagnosis of lung cancer, we have something called the TPS, the tumor proportion score, and you can take their pathological sample and you can stain it for PD-L1. And in patients whose cells express PD-L1 50% or higher, you say that's a high tumor, a high TPS, and they may respond to immunotherapy. So these are some major articles that were recently in the New England Journal of Medicine. So the one on your left is pembrolizumab versus chemotherapy in metastatic non-small cell lung cancer. So basically they took patients who had a tumor proportion score of 50% or higher. So they expressed a lot of PD-L1. They had a lot of anti-immune activity in their tumors. And they took these patients and said, okay, what if we give them pembrolizumab monotherapy? Remember, pembrolizumab blocks PD-1. Versus standard of care chemotherapy. And this graph here looks at the progression-free survival, and there was a very major difference. So if you look, let's just say 6 months out, you see the curve really drop for chemotherapy. And around 9 months out, you have a somewhat stable response for pembrolizumab. So over 50% of the patients have not progressed. So this isn't just that they're still alive, it's that they have not progressed. Their disease has not progressed. Whereas for chemotherapy, it's much lower, around under 20%. And then the next question was, okay, what if their tumors have PD-L1, but not as high as 50%? What if it's less, like less than 10%? Will they benefit from adding immunotherapy to the chemotherapy? And in this big study in 2018, they found that was the case. So this looks at overall survival. And if you add pembrolizumab to standard of care chemotherapy, let's look 12 months out. You have over 70% of patients still alive. And this is metastatic, remember. And then in patients on just the chemo plus placebo, it was a lot less. It was under 50%. So then the next question became, all right, so patients who have just a little bit of PD-L1 expression, let's say 1% or more, they do better when you add pembrolizumab to chemo, but what if you just give them pembrolizumab without chemo? So one of our most well-known oncology attendings here, Dr. Lopes, he presented at the plenary speech at ASCO last year, which is basically the biggest oncology talk in America. And he talked about the study called Keynote 42, where they addressed that question. So where they looked at patients who had a tumor proportion score that was PD-L1 positive, meaning 1% or higher, versus chemo, they actually did better with on just pembrolizumab, just immunotherapy, than just chemo. So this was huge because it led to a lot of changes in FDA regulations. So just last month, on my birthday, pembrolizumab was approved for first-line monotherapy for you guys distracted me. First-line monotherapy for non-small cell lung cancer that expressed PD-L1 1% or more. All right, so now I'm going to talk about this meta-analysis that I did with Dr. Lopes and Dr. Paul, one of our fellows. So it's called The Prevalence of Targetable Mutations in Black Patients with Lung Cancer, a Systematic Review and Meta-Analysis. So basically what we wanted to do in this meta-analysis is we knew that historically blacks have had poorer outcomes, and that's always been linked to socioeconomic status. But the question is, now that we have targeted therapies, now that we know that there are mutations that we can target, is it true that they still have disparities on a molecular basis? Is there a difference in the prevalence of targetable mutations that might lead them to continue to have negative treatment outcomes? So we looked at 4 different mutations, the 4 most common ones, which are EGFR, ALK, ROS1, and BRAF, and we tried to stratify the prevalence of these mutations by race. So the way we did this was we started with a lot of studies and ran them through various inclusion criteria. So we wanted to find studies that talked about one or more of these mutations. So there are a lot of papers that talk about just EGFR mutations. A lot of studies look at just ALK mutations, but it's rare to find studies that show all of them together. So that would have been pretty impossible to find a good amount of patients. So we found studies that showed the prevalence of at least one of these mutations. And next, we wanted to find studies that stratified by race. So if there's a study that shows EGFR, we needed to stratify by more than one race. And then finally, and this is what really cut down the amount of studies, we needed to to have black race as one of the races that we're stratified as. For example, EGFR mutations are very common in East Asia, so there are a lot of studies coming out of East Asia, but they don't stratify by race, especially they don't include black race. So at the end of the day, we ended up with 20 studies, but included a substantial amount of patients, 11,867. So these are the results, and I'll kind of walk you through the table. So all the way on the left, we look at the different mutations, which are EGFR, BRAF, ROS1, and ALK. So there were a total of about 15,000 mutations that were detected in these patients, and by far EGFR was the most common. It accounted for about 2/3 of the mutations. And then the four races we stratified by were Black, White, Hispanic, and Asian. So like I mentioned before, if you look at the Asian column, they have a very high percent of expressors of EGFR mutation, which means that almost half of these patients will benefit from a TKI or non-chemo versus chemo, which is pretty huge. And then we'll focus on EGFR since that's the most common mutation. So if you go to the left, Hispanic, there's still a pretty high amount, 35%. In white patients, 12%, and then in black patients, 6%. So black patients had by far the fewest, the lowest prevalence of this mutation, and that holds true basically with all four of the other mutations. Another important thing to look at, if you just focus on the white column and the black column. So in the white column, EGFR, there were 12% were mutated. If you add everything together, in the white column, 18% of white patients had a targetable mutation. Whereas if you look in the black column, that only adds up to 8% of patients had a targetable mutation. So basically, we found that there is a big difference in the prevalence of this mutation, of these mutations. So basically, the conclusion is that in the era of target therapy, certain patients do much, much better if they have a mutation that you can target. However, unfortunately, black patients, they are less eligible for these therapies because they have lower mutational frequencies. So basically, we need more research to see what we can do. But some ideas for now, there are a lot of clinical trials going on in non-small cell lung cancer. So we need greater enrollment. We need an active effort to try to enroll black patients in these studies. For example, there are KRAS, NRAS mutations, which are more common in smokers. So there are plenty of studies out there that we can enroll patients in. We also, on the primary care side for my fellow residents here, I think we can all do a better job of screening for low-dose CT. A lot of patients will tell you they smoke or they smoked, and they don't really quantify it, but maybe if we ask more questions, we can find more patients who we can find early-stage disease and prevent progression. And one thing I didn't write here, but I touched on earlier, is these are for tyrosine kinase inhibitors, but immunotherapy is really exploding right now. And basically, all of these patients should ideally be screened, if they get a biopsy, they should be screened for PD-L1. Because even if you have a black patient who does not have a targetable mutation, they may express PD-L1, and they may do a lot better with immunotherapy, not just in terms of outcomes, but in terms of side effects. A lot of immunotherapy has its own side effects, but in the general population, it tends to be much better than systemic chemo. So that's it.
Good job, Sunil. Very good. Dr. Lockhart.
Great job.
Thank
Great
you.
job. I remember working with you many, many years ago when you didn't really know anything.
There was never a time. When
Never a time. Okay. I apologize. So with the with the EGFR mutation, there's an association with smoking. Did you have enough numbers from the meta-analysis to look at smokers versus non-smokers in the black population versus the white? Did you have enough numbers to do that?
We did, and I didn't include it in here, and we're actually writing up the full manuscript, but even if you stratify by smoking status, the EGFR mutations, you still saw the same pattern. Okay. Especially in Asian females specifically who never smoked, they have a very high prevalence. Yeah.
Looking at racial disparities, of course, is extremely important, and part of that is being able to define the groups accurately. How did you define your black population? Was it self-described, or was there, Latino populations can be very heterogeneous, as can black. So how did you look at that?
So as a meta-analysis, we looked at a lot of different studies and kind of had to go off how it was reported in that study. In some studies, it was self-described. In other studies, it was described by the people conducting the study. But you're absolutely right, and especially in the Latin population. For example, we know that EGFR mutations are more common in Latin countries with heavy Asian immigration, especially Peru. So it definitely varies a lot.
Does one of the residents have a question?
Charlotte.
Yeah, just kind of jumping off of Dr. Weiss's question. I think that there's kind of like a pull in two different directions in medicine right now. One of the directions is really kind of defining population-specific therapies, and then another big area in medicine right now is like debunking these ideas that that there are medications that we can prescribe for racially distinct populations, and recognizing that the vast majority of genomes we share 99% of our genome, and there's more
Similar.
variation within groups than between what we have come to define as racial groups. And so I guess I wonder how you make sense of that, but then trying to find these racially specific therapies for patients, given that we recognize that there's a lot more inter-group variation than inter-group variation.
Yeah, so even basically the point of the study wasn't trying to prescribe any racially specific treatment. It's just really talking about the finding that that we found. But I think on the contrary, like you're saying, in East Asia, pretty much everyone is screened for EGFR because it's that common. In African American heavy populations here, probably far fewer are. So I agree with what you're saying, how we should test everyone for all of these things. There's a cost issue, there's an access issue, but no, I agree. This is just a finding, but we should not use it to discriminate more in terms of screening.
Well, I'm very proud of both our former and current House officers for presenting such excellent grand rounds, and look forward to next year's cadre. Oh, we have one more question. Yes.
I also have a question on point that in your slide, you mentioned a few things throughout, which was like implicit bias as in terms of changing different. That's just racism. I think we should start using that word more, because it doesn't mean individual decisions. It's just a structural, implication for favoring or for making decisions based on one group or the other. So implicit bias is just a form of racism. And then in the very beginning, you mentioned that that is one factor for the changes in outcomes that occur, because different treatment, the quality of treatment is given differently to different groups. And so in the first slide, you mentioned favorable and unfavorable demographics, and one of them was favorable Asian, unfavorable was Black. And so I think that for people, when they say that, they might pull on all of those inaccuracies that exist based on the word unfavorable and Black, unfavorable and Asian, and do a disservice to patients, because you assume that they're Asian, they're going to do well, and they don't necessarily get the same evaluation. Versus those words are like proxies for other things like social determinants of health and research that's not completed in different populations because of color treatment and stuff like that. So I think recognizing that race itself within research itself is like a proxy for a lot of other variables that are hard to study sometimes, or that we don't study very well in certain groups because of existing and historical and ongoing racism that occurs.
Thank you for that comment.
Thank you.
Thank you, everyone.